So I will start, and in a moment it will be my pleasure to introduce Ruben to take us a different position. So as I say, I'm in a slightly sort of challenging position because I'm going to be talking 3 drugs for younger patients versus 4 for younger patients. But what I want to try and frame this in is the concept of understanding that perhaps there's an upper threshold to how much we should use, or should we think about a fundamental platform to which we then rationally add, as opposed to simply reaching automatically for 4 + 5 or so on. So I think, again, what you may hear, as I mentioned earlier, is a lot of overlap in our opinions here. But hopefully, regardless, this will inform you. Okay, now, I've already touched on this. I don't want to belabor it. But we've talked already about risk stratification. We've recognized clonal heterogeneity, individualization of treatment as everything, and the advent of novel therapies has changed that. With the progress that we have, we've got a better understanding of disease biology. We've seen substantial improvements in outcome through the availability of newer and effective treatments. And this is the posit of the 3-drug platform, that essentially you have a therapeutic backbone of a proteasome inhibitor, an IMiD, obviously, and a complementary steroid or other rational novel agent. But do you need to do more? For example, do you need to add cytotoxics to it? That's going to be essentially the question from my position this morning. The important point, to echo what Saga said, is the recognition that even in the younger patient, we have to be very much aware of the long-term consequences of our chemotherapeutics and how they may impact on toxicity. So our challenges remain that the disease is incurable. Very importantly, there's an increasing symptom burden due to disease and cumulative effects, and managing the balance of disease control and quality of life, I would argue, is just as important for the younger patient as it is for the older. And I would suggest a different thought here as well. Our younger patients in their 50s, 40s, early 60s, we're looking to 15 to 20-year survivals. So it becomes even more important to understand the long-term consequences of what we do. So my position would be that whilst we think of 3 versus 4 drugs in this context, I would simply argue, think of a platform of immunomodulation, proteasome inhibition, and other rational novel agent, but let's please be careful about simply adding a cytotoxic, for example, to that platform in a less rational fashion when we're looking towards the concepts of long-term toxicities and tolerability issues. Now, to frame this and to sort of give you context, I think it's important to recognize that our older regimens in the younger patients obviously are now obsolete. Thalidomide and dexamethasone at its time was a real revolution, but obviously rapidly superseded by RD, and then the 3-drug combinations followed shortly thereafter. What I want to sort of suggest to you, though, is when we moved into the era of the 4-drug platform, obviously, did we see a dramatic difference in outcome? Well, some studies would suggest not, and I'll come to this in just a moment. Here you can see actually representative data from a 3-drug platform of IMiD, proteasome inhibitor, and dexamethasone compared to the same platform with the addition of liposomal doxorubicin and with the addition of cyclophosphamide. Now, obviously in that context, we saw actually more toxicities with the addition of the chemotherapeutics to this platform, and indeed in the evolution trial that was led by Shaji Kumar, in which it was our privilege to be part of, we actually showed that the outcomes were inferior for this 4-drug platform in that context. So Shaji's conclusion was that actually the 3-drug platforms from that 3-arm trial actually were the one to go forward with. Now, one important point, of course, is that we also have more exciting and even more potent proteasome inhibitors on the horizon, and we're going to come to carfilzomib in just a minute. But I think it's important to share the current US-EU perspective in the younger patients, and there's a strong preference for 3-drug regimens, as we mentioned earlier, but not just simply in obviously the older population, but the younger population too. Now, what I would share with you here is, I think, an important construct, that as we think about the success of combinations such as VTD and RVD, and then the relative limitations of adding conventional chemotherapeutics, what's really exciting has been the next generation new agents. Obviously, the very potent, irreversible effects on the proteasome of carfilzomib lead it to be an excellent combinatorial partner with IMiDs, and we've seen dramatic results not just from carfilzomib, lenalidomide, and dexamethasone up front. Obviously, I've already touched on the RID regimen, but very importantly, we obviously now have the advent of the antibodies. So the question will be, recognizing the lessons that we have from here, that there actually may not be a huge amount of benefit from the addition of conventional cytotoxics. What happens when we rationally integrate some of our next generation novel agents? And I think that's the key hub of the question this morning. How much more is enough to achieve that, and what about overlapping toxicities with newer or novel agents, and how do we best integrate them? This is very nice data from Andres Jakubowiak, which I'm sure you're all familiar with, and essentially what's important to note here is the very high qualities of response and the improvement over time. As we've discussed before, the neurotoxicity is minimal with this regimen, which is great news, but also do beware that there are these other less common, rarer side effects, but they're important, including the shortness of breath, including some of the cardiopulmonary toxicity and renal toxicity that can be seen, but again, uncommon and generally very manageable. And this is particularly exciting when you think about it in the context of the data I'm just going to show you here. This is from Ola Longren's group at the NCI when he was there before coming up to Memorial. But what you can see in his CRD study in upfront patients is the remarkably high rate of quality responses seen with this 3-drug platform. And very excitingly, as you can see, a very high rate of near CR and CR that's generated. Now, recognizing that adding cytotoxics to this platform may be very challenging and add toxicity without improvements in benefit, what then would be the rationale for other novel drugs? And we've got some very interesting constructs here. Many of you may be familiar with the excitement now around deacetylase inhibitors with the recent approval of panabinostat, which I think opens the door to a whole new array of drugs that will be coming through that pipeline. And they're summarized here, including ricolinostat, which is a more selective and arguably less toxic HDAC that is showing great promise in current trials. But obviously this whole area is opening up, and the question will be, would this be a rational fourth drug? And I will suggest to you it most certainly should be, and there's evidence to support this. I'm going to profile some work done in partnership with Saga and Jonathan at Emory, where Saga and Jonathan led this trial, the so-called R2V2 study, and we're very impressed by this. Very high qualities of response and excellent tolerability actually overall. The question that I would propose to you is that we have that 3-drug platform and then we rationally add to it potentially, but I would suggest to you that's not necessarily the case that we have to do in everyone. Another example of how this can work in our favor is this study, the PAN-RVD trial with panabinostat. This was led by actually Jatin Char and Bob Olosky. And just to show you here, very high qualities of response early in the disease. But the challenge here is, again, the tolerability profile. The very good news, though, is with subcutaneous bortezomib, this was well tolerated. But my point is that in every patient, should they get an HDAC added to this platform, we simply don't know yet. And I think in that context, the argument that 3 drugs should be our immediate standard makes sense, with the question of whether we add the fourth dependent on other aspects. Now, one point to simply make here too, in younger patients, just as I alluded to the fact that ixazomib can be given weekly in the context of the older, frailer patient, there is evidence from prospective trials that we've done looking at twice a week ixazomib, that this can be a very active platform. As you can see, very high qualities of response. Tolerability may be an issue, but nonetheless, this is a 3-drug platform, all oral of just those 3 drugs. And as you can see, we're seeing very high quality of responses, which is impressive to us. And again, I would mention from this combination approach, whilst weekly is the platform that's been taken forward in terms of the approval strategies, we were very struck that with the twice-a-week schedule in our younger patients in this group in this study, the activity was particularly impressive. And this is actually an analysis of the MRD analysis, which shows to you very encouraging results, very similar to what I showed you before. Now, as we think about 3-drug platforms, we recognize that it has to have, obviously, the 3 components, the immunomodulation, the steroid, and the proteasome inhibition. And that's summarized here, as you can see from an early analysis by Antonio, showing the benefit of bortezomib in this platform. Our own RVD work has supported this, and also work from Saga's group has showed this very nicely, allowing us to be able to delay transplant, we would suggest, in these retrospective analyses. Having said that, as we go forward, it's critical to know about the randomized trials that will support us in the understanding of where transplant belongs in this context. And I simply want to make a brief plug, if I may, for our prospective randomized trial that's ongoing, the so-called determination trial, which is continuing to accrue very nicely now in the US. And for those of you who are close to any of the centers, there are over almost now 50 across the country, we'd welcome your participation. Another study that's ongoing that's recently completed its accrual is the EMN study looking at this question. And I simply bring this into the discussion this morning to illustrate the point that just as we're thinking 3 drugs is the standard, where does transplant belong? That's exactly the point here. Where does transplant belong, and where does the impact of intensive therapy or consolidation and intensification using chemotherapy belong? And there we have obviously an open question. We already heard of, and I don't want to repeat this, but at least this is a different slide, again, the impact of antibodies. Where will they belong in this platform? And I'm sure Ruben will touch on this. My simple point would be is that I can see this clearly being an add-on to the 3-drug platform as we go forward in younger patients, and this may be truly transformative. But I would suggest to you, until we have those trial data, it's very important to recognize that this, whilst it's a view of the future, must be something we approach with some caution until we have additional data to support its use in the upfront setting. And again, I won't dwell on these because these are obviously things we've touched on before. I'll come back to this a little bit later, but my simple point here is that the immune suppressive microenvironment in myeloma is very important. There are going to be rational ways we go after that with immunotherapeutic strategies that manipulate the immune response. The reason I show this slide, though, is to emphasize that as we think about multiple drug combinations in the upfront setting, we must remember that we need to preserve, to the greatest degree that we can, a relatively intact immune repertoire. So therefore, as we rationally put together combinations, we must remember that some of our strategies may actually be more immunosuppressive than not, and that becomes relevant. This is also a concept that I think is important to bear in mind. It's a fascinating rationale behind why combinatorial strategies may work. Interestingly, in this particular dissection of the mechanism of immunomodulatory drugs, it argues that there may in fact be actually some antagonism with proteasome inhibition based upon this modeling. Obviously, what we see is the opposite. So I would simply also propose to you, as we think about putting multiple drugs together, we need to be very careful, because you may need to be aware of, as it were, the law of unexpected consequences. This actually is completely superseded by the preclinical and clinical work we have showing synergy. And from sitting down with investigators, this is led actually by Bill Kalin's group at our center at Dana-Farber, sitting down with Bill and sort of thinking this through, it's obvious that there is something different going on here that we need to better understand. And my point of showing this slide is simply to say to you that the random augmentation of multiple drugs without being properly informed about what you may be doing is very important. So I'm going to very now quickly close by simply saying to you and sort of reiterating a point that we made earlier, that as we think of all these drug combinations, we have to be very careful about rationally putting them together. We need to think about what may in fact be the true backbone, as it were, of 3 drugs. And as we add drugs to that, I would propose to you, it's certainly reasonable, but it really honestly must be rational. So until we have further information from prospective trials, I propose once again that for younger patients, the 3-drug platform remains the standard, and then as we add to it, I would only caution that that needs to be done in terms of rational trial design and participation in clinical trials, because at the end of the day, we always run the risk that triplets will thus be the new standard, but additional agents need to be added through innovative prognostics and other strategies. And for example, use of gene expression profiling and other strategies will inform that. And my point simply here is that in that context, I would simply close by the simple comment that one size therefore does not fit all. And I want to thank you for your kind attention.